homeostasis.
Depending on the foregut and hindgut theories, there are 4 different techniques of surgical treatment available presently for diabetes.
One is the sleeve gastrectomy alone. This sleeve gastrectomy alone, we are doing it for little obese patients, like the BMI is more than 30. So the other depends on the foregut theory alone. It is the DJB, that is the duodenojejunal bypass. In that, we will just divert the duodenum and the jejunum from the passage of the food into the ileum. And it depends on the hindgut theory. It is the standard ileal interposition. That means 170 centimeters of the terminal ileum. That is from 30 centimeters from the ileocecal junction. We will measure 170 centimeters of the ileum, and that with its mesentery we will interpose in between the jejunum. That is 20 centimeters from the DJ junction. We will make a cut and we will interpose this ileal segment into the jejunum. That is known as the standard ileal interposition. Combining these two theories, that is the foregut and hindgut theory, there is a diverted ileal interposition. In that, we will divide the D1, and the D1 is connected to the ileal. We will take this 170 centimeters of the ileum, and the ileum will be directly connected to the duodenum, so that the food will directly enter into the ileum, and at the same time it will divert from the duodenum and the jejunum. So there will be the both actions. The anti-incretins level will come down and the incretins level will go up. So this is known as the diverted ileal interposition. All these operations will be combined with a loose sleeve gastrectomy. This has got two advantages. That is, we will the reduction of the ghrelin level in the bloodstream, which will again has got a better glucose homeostasis, and similarly the early passage of the food from the stomach into the ileum again have got a better glucose homeostasis. So these are the operations available.
These surgical techniques for diabetes is in the phase of clinical trial in various centers of the world, and the longest outcome duration is 8 years in 2011.
In non-obese patients, the largest series available is with Dr. Orio DiPolo, and he was doing this surgery for last 7 years. For more than 600 patients he has done, and his result is very much exciting, because more than 90% of his patients are off the medicines, and the rest of the 10% of the patients he can reduce the dosage of the insulin, or from the insulin he can come out with the OHA. So definitely the result is very much exciting.
Currently, the clinical trial for these surgical modalities of diabetes treatment is conducted in 5 centers across India, and the laparoscopy surgery department of the Maulana Hospital, Perindalmanna in Kerala, under the dynamic leadership of Dr. Muhammad Ismail, is the largest center in this field in India.
We have got from the National Clinical Registry, we are allowed to do 20 surgeries. That is 5 in 4 limbs. That is 5 patients with sleeve gastrectomy alone, and 5 DJB, 5 standard ileal interposition, and 5 the diverter interposition. We have already done 9 patients, non-obese patients, and the initial results are really exciting. Now this result is almost 6 months, and already all the 4 patients are out of medicines, and the other 5 patients are the doses could be considerably reduced.
Apart from the clinical trials, there are results from extensive animal model studies conducted internationally across the US and UK.
One of the very famous studies is that in GK rats, that is a typically congenital type 2 diabetes rats, which are very slim rats. They have got hyperinsulinemia, they have got the insulin resistance, all the typical type 2 diabetes rats. And in these rats, they have done these surgeries, and they found that the blood sugar levels is drastically coming down. It is coming down to normal. And the same rats, they have redo the procedure, and then the diabetes is coming out. That is, the glucose is going up. So this is a very famous experimental study. So there are a lot of animal studies from the US.
Being in the clinical trial phase, the inclusion-exclusion criteria for diabetes surgery is very meticulous.
The selection of these patients is very stringent because we have to take these patients, those who are having good beta cell storage. What happens, that in type 2 diabetes mellitus there will be beta cell storage, but the secretion of the insulin from the pancreas is decreased because of the various factors. So to know whether what is the beta cell storage, we have got a battery of investigations, and we have to take only the typical type 2 diabetes mellitus patient. And the type 2 diabetes mellitus itself, there is a lot of other variants like maturity onset diabetes mellitus, LADA, the patients with islet cell antibodies, GADA antibodies. So all these patients we have to exclude by doing a battery of investigations. Then only we can select these patients for a surgery. And the main investigations we are doing is the fasting C-peptide level, which gives a fair good amount of the knowledge how is the beta cell activity, and of course the islet cell antibodies, the GADA antibodies, and the pro-insulin-insulin ratio, the fasting insulin ratio, and all the other investigations like the hormonal assays, whether the patient is having some other diseases, and the age of these patients, we usually select these patients little more younger age.
For a novel concept like diabetes surgery, the question of chances for complication should be addressed with prime importance.
For the patient, the surgery should be as safe as they are taking a tablet or taking a dose of the insulin. There should not be any complications in these surgeries, because we are from the patient's part, we are not operating in a cancer patients. So for them, by taking a tablet or the insulin, there won't be any problem, or maybe in long-term complications it is there, that we know. These surgeries we are doing it very meticulously. There should not be any scope for any type of the complication in these patients.
The